Coming to the diagnosis of rheumatoid arthritis. First of all, this is our first topic today. As you know, right now, there's morning sickness is a very, very important thing which you need to remember. Now, coming to the diagnosis of rheumatoid arthritis, first of all, you have to check whether there is a symmetrical polyarthropathy. Rheumatoid arthritis means there is a symmetrical polyarthropathy. Multiple joints are being affected. So there are multiple scales on the basis of which you will diagnose rheumatoid arthritis. Now, remember, scales and exact value of scale are not required to be remembered. But few things always remember. It is more likely to be a rheumatoid arthritis. We look at the writing that I am writing right now. It is more likely to be rheumatoid arthritis if it is polyarticular. Okay, and if multiple small joints are affected, if there is redness, swollen, tender joints, and their number is more, if CRP, ESR, these are high, these are the markers. If you are not having any query, please mute yourself, or admin, please look into this. Then certain factors that we have to check for rheumatoid arthritis, these factors are a factor. But remember, 70% of cases RA factor is positive. There are 30% cases of rheumatoid arthritis where RA factor may not be positive. Then ANA. ANA is a very non-specific, and almost in all rheumatological condition, ANA may go high. Then comes very importantly, very specific for rheumatoid arthritis, that is CCP antibody. Mostly up to 95% of cases, you will be finding CCP antibody being positive, but there are still chances that 5% of cases CCP antibody may be negative. Now, one concept comes here. What is seronegative rheumatoid arthritis or seronegative arthropathy? Seronegative means only rheumatoid factor, RA factor is not positive. That is enough. If that is present, that is known as seronegative. Now, let us come to certain contents. So, RA factor, what is that? They ask multiple times in the examination. This is an IgM type of antibody. And this IgM that acts, that reacts with FC portion of patient's own IgG, and that causes this issue. What else? How we check RA factor? We check RA factor by latex agglutination. All these are questions to remember. And Rosewaller test, where sheep RBC agglutination is, is done. Now, 70 to 80% patients would be RA factor positive. The higher titer, these are the questions. Higher titer RA factor, it is showing that our disease is more progressive. But always remember, RA factor is not a marker of disease activity. So, who are disease activity marker? Your ESR, your CRP, your clinical condition. These are the disease activity marker, not RA factor. Again, another point which is important here, because most of this time, rheumatoid arthritis patient, they do have anemia of chronic disease. So if you find in a patient that anemia of chronic disease is there, that means the disease is active and disease is prolonged. That is also a very important point that you need to remember. But always remember, RA factor is not very specific. Which one is the most specific? That is the CCP and ECCP antibody. We are coming to that. It is also present in Sjogren's syndrome, Felty syndrome. We are coming to it. It is RA with splenomegaly. Then infective endocarditis, 50%. This percentage that is written, these are for the number of cases where it may be, or percentage of cases where it can be positive. SLE also we get RA factor positive. SS means systemic sclerosis I am talking about. Physiologically, 5% cases or 5% of the population may get RA factor positive. And multiple infection, apart from the rheumatological condition, there RA factor may be falsely positive, like tuberculosis, HBV, EB virus, and leprosy. Do not have to write all these things. You can take a snapshot and we can move on because a lot of information are there. Try to write what extra thing I'm telling in between. That will be the tips for the examination. Now, coming to the CCP, I have seen questions where they have asked for the full form of CCP in part 1. So be a little bit careful about that. That is anti-cyclic citrulinated peptide. This is something you need to tell. And then always remember, often predated. What does that mean? That CCP may be positive. CCP may be positive even much before the disease is there. So this is something you need to remember. The specificity is very important. 90 to 95% cases, it is specific. Predated means again another thing that it can also be a target for the therapy, because if you get CCP positive, biologics can be targeted and newer researches are running in that direction. That means even before full-blown RA features are there, but patient may still have issues like that, and you can try with the biologic. This question will not be asked in the examination, just for your information. Anything? Any query? Anything? Any query? If you have any query, okay. If you don't have any query, please mute, because it is very disturbing in between. Now, coming to clinical features of RA. Admin, please mute if somebody doesn't have any query or if somebody's mic is mistakenly on.
Hello?
Hello?
Ji.
Boliye. Okay. Okay, this was inflammatory.
ठीक है, भेजो दे। हाँ, ठीक है।
How should we react rheumatologically to this? Anyway, clinical features of RA. So musculoskeletal features may be there, extra-articular features may be there. So Royal College is a very fond of asking you associated features and extra-articular features. So in extra-articular feature, I have written only the names: RESP, IHD, MDD, major depressive disorder, and increased chance of infection. Let us one after another we should go. So respiratory, there is a chance of fibrosis, any type of fibrosis associated with pulmonary fibrosis. So the chance of ILD, that also increases with rheumatoid arthritis. This is also present in systemic sclerosis, also present in MCTD, also present in SLE, different other rheumatological condition also, this can be present. In case of eye, there might be uveitis. In case of eye, there might be uveitis, and in case of eye, there might be episcleritis, scleritis, multiple inflammatory changes you might find in the eye. In case of IHD, in case of extra-articular thing, always remember this question has come: RA makes you prone to developing IHD and CAD, coronary artery disease. So this is something, and that's why regularly comorbidity checking is important in the patient who are having RA. So I'm not asking every 6 months you go for echo, but Royal College is asking that regularly you just keep in mind, and this thing may be tested in the examination. Infection, definitely due to many things, their immunity is already dysfunctional, and most of these patients are on multiple medications, so that can lead to a higher chance of infection. Many times you will be seeing associated condition with rheumatoid arthritis. So one is the Felty syndrome. What is Felty syndrome? That is RA, splenomegaly, and low WBC. Questions will be like that. In the question, you will be seeing they are mentioning that ultrasound showing this, and simultaneously the total count is low on the picture. So this is Felty syndrome. Occasionally amyloidosis is also connected with this. This will be secondary amyloidosis. Now coming to the musculoskeletal feature, for diagnosis we need multiple scoring. Now remember, you don't have to go for the scoring. Just remember, if more number of joints affected and more number of small joints affected, higher chance of it being rheumatoid arthritis. Check for RF and CCP. If it is negative completely, the score is 0. And if it is faintly positive and higher titer positive, the score becomes 1 and 2. So the more positivity, the higher chance of rheumatoid arthritis. Again, remember, even if it is 0 RF factor negative, it can still be rheumatoid arthritis, but those are seronegative rheumatoid arthritis. Coming to CRP and ESR, the lesser chance of RA, the higher chance of active RA. Always remember, a patient who is in remission or who is right now being treated for RA may have CRP and ESR normal. That is due to the treatment and duration. If it is for shorter duration, less than 6 weeks, it is unlikely. It is more than 6 weeks, it's likely. So I'm taking it from the score just to give you the idea. Have the idea, don't have to remember or memorize the score. Coming to one more thing, the prognostication and the severity of RA also depends on DAS28 score. That is a disease activity you can identify from there. Again, this score, this scale, you don't have to remember in the examination, but what is the outcome of this score? This through this scale, you can identify the activity of the disease. That is something you can remember. Okay. Now, approach to a particular thing. Symptoms, you all know, it is symmetrical bilateral small joint involvement, small joint, hand joint, total inflamed joint, and the swelling joint. This has to be done in actually regular practice. Here, you will be provided with the information. Females are more than in male. Morning stiffness. Usually, in Royal College person, they give you 30 minutes to 1 hour of morning stiffness. Very specifically, they will mention swollen and hot joints also are very important. Along with this, there will be systemic symptoms. These are very important. Systemic symptoms. Some patients might have fever or malaise and other type of systemic upset, which may be concomitant with rheumatoid arthritis. Now, prognosis. This is very important question for the examination. You just have to memorize this table. Prognosis is worse if RA factor is positive, and the higher positivity, the poorer prognosis. Poor initial functional status. This is poor initial functional status. So at the diagnosis, the patient condition is, the baseline condition is not good, so prognosis is bad. HLA-D4 positivity, it is again rheumatoid arthritis associated with HLA-D4 positivity. In some cases, in that case, it becomes monogenic. So that also goes for poor prognosis and X-ray showing early erosion. I have pictures for X-ray. I will also discuss the X-ray. CCP positive, all cases are definitely poor prognostic. Extra-articular feature, nodules. Nodules means in extensor surface, you will be seeing the nodules. In cases, whenever you are finding, check the elbow of the rheumatoid arthritis patient and check for the nodules, whether it is there. And female gender, that is again for the poor prognosis. So this is a poor prognostication question. You can surely get some question from here. Take a snapshot and we need to move on. Now coming to the treatment. Treatment aspect, definitely non-pharmacological, pharmacological, a lot of treatments options are there. So in non-pharmacological, certain points, occasionally it is there that the social support, and these are important from our subcontinental texture. These are not important that much, but there it is very important. It can be also in the next step of the management can be this kind of thing. Remember that social support. All chronic disease, they do have society. So rheumatological society, RA society, something, all chronic alcoholic society, every chronic issue, addiction, everything has society. Remember that one. And definitely occupational health. So occupational health support, these are certain things that you need to remember. Coming to the pharmacological, that's the most important thing over here. So what are the pharmacological therapy that is possible? First, I need to do some pain relief. So how pain relief is possible? Pain relief first option is the NSAIDs, definitely, or steroids also an option. These two are the option depending on the scenario. Which type of patient you can give NSAID if the renal profile is okay. For a shorter period, you can give. That is always the first line of treatment. Remember, poor opioids, poorly acting opioids and paracetamol are almost ineffective in such cases. Coming to the steroids, definitely you can give, but there are this gives in case of flare you can give. If you are not being able to completely settle down the symptoms with NSAID, you can go for the steroid. These are the things that are important. Now, NICE guideline is saying if even after giving this, the patient is still not in remission within 3 months, the patient is positive case, rheumatoid arthritis, CCP is high titer is there. So within 3 months, it is better to start DMARD. So DMARD. So what is this DMARD? These are disease modifying agents. And what are the DMARD they ask for? One is the methotrexate. Okay. And usually this methotrexate is started from 7.5 per week, but you can go up to 25 per week within the capacity of secondary care. Then even after above that, it is a little bit tricky, and by that time, definitely we have to think of certain other biologics and stuff. The methotrexate is there, and then what else? Definitely, we have to give a folic acid cover with the methotrexate. Usually, it is given on other days of the week, usually 1 day or 2 days a week. Other than the day you are taking methotrexate, you have to give very, very careful that it is a weekly dose. It is not at all. It is a 7.5, not 75. It is a weekly dose. It is not a daily dose. Very, very careful about that. The second one is sulfasalazine. So I'm writing a very common brand name for that. Basically, sulfasalazine can be used. Third one is the leflunomide, and the fourth one that we can use the HCQS. These are the four agents that we can use as a DMARD in rheumatoid arthritis. There are other options in DMARD, but not used nowadays. One is penicillamine. Then also there was gold salts. These are there, but not used nowadays. So these four are given. Now always remember, they ask you to start with, if there are no contraindication, you can start with 2 DMARD and regularly review the patient. Now, what are the points that you have to check before starting a DMARD? So definitely, each and every DMARD, they do have their side effects. So a little bit about side effects of everyone. You can also write simultaneously. You have to be very quick. Methotrexate, bone marrow suppression, it can cause. What else? All 3 lineages may go down. Individual lineages may go down in case of blood. What else? Long-term methotrexate may lead to pulmonary fibrosis, drug-related ILD. That can happen. What else? It can be problematic to kidney, can be more problematic to liver. So if the patient is already having some liver disease or so, be a little bit cautious. Already having pulmonary hypertension, already having pulmonary fibrosis, be a little bit cautious. Specifically in case of fibrosis, if the ILD is already there. So this is one. Sulfasalazine, again, there are certain contraindication, and one caution is there. It is somehow related to pancreatitis. This is something occasionally you may need to think of. Coming to the leflunomide, the main side effect is the high BP. So it can increase the BP, and in very high or hypertensive urgency, the patient, you should not initiate that. HCQS is the fourth option, and HCQS, the problem with HCQS is the retinopathy. So these are the certain contraindication that you need to remember for the patient. Now coming to the fact that suppose there are some other option, like suppose leflunomide is also teratogenic. Leflunomide is also teratogenic. Okay, methotrexate is teratogenic. Now, if I ask any of you, you can also write in the message box, if the patient is pregnant, which of these you can give in case of DMARD? And, okay. Anything? Can HCQS be given?
Yes.
Yes. Can leflunomide be given? No. Can methotrexate be given? Can methotrexate be given?
Methotrexate, no.
No. Okay. So usually the sulfasalazine is an option, HCQS is an option, and steroid is always an option. So these 3 we can go for. Now coming to the fact that if suppose the patient is doing okay, no problem, but so you see that you are not getting good result with this. So what to do next? So what are the options? So NICE guidelines are saying for certain biologicals, definitely, and usually these biologicals are few types. These biologicals are TNF-alpha inhibitors, like infliximab. There's biologicals, infliximab, etanercept, and adalimumab. These are the TNF-alpha inhibitors. We have beta cell depleters. So rituximab, it can also be used. This is etanercept. Infliximab, adalimumab. Okay. And also IL-1, IL-6 inhibitors. This we can use. So IL-6 blocker, one important one is tocilizumab. These are the things that we can give. But again, remember, most important question they ask. These are not the question. This is not like Indian exam where names are asked very, very much. Most important question they ask, when. So when and how to start biologics. So only thing is to remember that adequate trial of 2 DMARD. One of them must be a methotrexate, initiated by rheumatologist. So what is that? Let me tell you again to make it even more clear. Suppose the patient is on these two drugs, even after a certain period of time decided by the rheumatologist, usually 3 months or so, if still the patient is not in remission, then it should be initiated by rheumatologists. The biologics may be an option. Occasionally, some biologics we can give along with the previous DMARD or previous two DMARDs are running, the biologics may be added. This much is sufficient for your part one examination. Now, very important. Can you tell me one adverse effect of the biologics? What we have to check before initiating biologics?
Tuberculosis.
Yes?
Tuberculosis.
Which one? Yes, definitely. So there is a high chance. Yes, yes. So there is a high chance of reactivation of latent TB, or if they already the patient is having active TB, it may be flared up. This is something. Anything else? Anything else? It's always useful to check the hepatitis B status, and if not, if not vaccinated, should be vaccinated before that, and definitely sepsis and stuff, because we are dealing with, immunomodulating a very dangerous. Is this a question? Okay. Anyway, okay. So this is okay.